So we'll call up our next panelist, the Honorable Judge Blair Edwards, Attorney General's Office, Randy Henagan, Jennifer Holmes, who we met earlier, and Lee Jones with the USDA. Thank you all for being here. We'll start with our next round of questioning. Thank you all. I'll start with Judge Edwards. Judge Edwards, let's talk a little bit about drug court, law enforcement, all of the opportunities out there, and kind of the transition from, incarceration to being out there with the public, and also just some of the programs out there and some of the challenges you see.
One of the largest challenges I see, I do 2 juvenile drug courts, and I do exclusive juvenile, and what I see is I do child protection cases, and delinquency cases. And what I can honestly say is that every delinquency case, almost without fail, should have been a child protection case that was gone undetected or unnoticed, which could probably have been detected through a truancy program, a very intensive truancy program. And what I have noticed is that while we have juveniles in our juvenile drug court program, we now have gone to duly adjudicating a family in needs of services to give jurisdiction over the family, because it is not just one person or one thing that has caused this to be a substance use disorder. And so much of what we are finding is that in order to be able to treat the child, the family, the addict, you have to understand the problem and the symptoms of the problem, and you have to be trauma informed. So you cannot just treat addiction. Addiction by itself is the result of a problem. And so in order to treat the addiction, we have to look to what is causing the problem. However, some people are predisposed. My younger brother was, and had a story, unfortunately ended up a very violent ending, but a very happy ending as well. Was in a car accident. It was a fatal accident for the other driver who did nothing wrong. And my brother ended up having to go away, go to the Texas house, it was a long, drawn-out journey. He's clean for 9 years. He has twins. He's raising his 9-year-old. It is an amazing story. However, the problem is, or one of the things I see as a barrier to being able for any service to be, is that when we look at the opioid epidemic, they say, wow, the United States, it's crazy. It absolutely is. And when you take a global approach, and I mean really global approach, and in what I do, I have done a lot of research. In Japan, they don't have this problem. In Europe, they don't have this problem. And you say, so why not? Are people not predisposed to addiction over there? And here's the issue. Insurance companies do not cover opioids in those places. 50% of their doctors are writing prescriptions, whereas 91% are writing prescriptions here. They're not writing prescriptions for every time you go to the emergency room. And our doctors are not wrong in what they're doing. They have every right. It's legal. Some may be overprescribing, but they have to have an acute illness. And I have so many parents that come in, and I've had many parents that come in and their words are slurring as we're in drug court. It always goes back, but I have a prescription. Yeah. They trust their doctors. And so the barriers, I think, to treatment in one regard is that we have to take a look at what is our tolerance level as a community, in a state. Do you realize that our state, that we write more prescriptions per resident than we have in the state, than we have residents? And so I think those are alarming statistics that we need to look at. In Japan, they only write it if you have an acute symptom and if you are terminally ill. And so when we are providing when we go to treatment centers and I send a child to a treatment facility, they only cover 28 days. That's enough to maybe get someone clean from marijuana when you're a child. And so we're spending the money, our insurance companies are covering the cost for the drugs, but they're not covering the cost of the treatment. And in Louisiana, I think the study showed in 2009 from Columbia University, for every dollar that we spend for substance abuse, we spend 3 cents for treatment, for prevention treatment, and 97 cents for consequences and incarceration. Seems to me like that needs to be flipped. Let's take care of the problem, because a Band-Aid costs way more. It costs $50,000 a year to incarcerate an adult. It costs almost $100,000 a year to incarcerate a juvenile. And we spend on true education in the public school system $11,000 a year on educating a child. These numbers are extremely skewed. So I think it's just, we have to look at what our level of tolerance is. Are we willing to say, okay, insurance companies, cover us taking all these drugs, cover the prescriptions, but then yet they don't cover the treatment. Drug courts work, but there's a lack of funding. There is a lack of funding, and certainly you have to have consequences and all of these things, but yet it doesn't matter. We don't have the funds to incarcerate, yet alone to have drug courts. I get threatened every year that they're going to take away and cut my drug court program. I have one of the largest juvenile drug court programs in the state. We work through treatment with trauma. We work with the parents. And yet I say, what about a truancy program? And people say, oh, they're just missing school. No, they're missing school for a reason. And when you get into the home of a kindergartner and a third grader, that's where you can make a difference for treatment for the parents so that the child doesn't follow in the cycle. And so I think those are things that we have, but we don't. And another thing that we don't have, you try to find a treatment facility for a female. Try to find a treatment facility for a female. And then look at the cost that we're incurring to place a child into foster care. So the treatment needs to be there. We are limited in our state. We are limited in our funds. But we sure are shelling out the money to pay for prescription opioids. And we're sure shelling out the money to incarcerate our society members. We've got to get and look, and I beg everyone, and we will be doing a documentary, look at the re-entry program for Angola. That's one of the most amazing programs in the nation, people. Right here, we got that right. But you know how long they have to stay in there in the program? For 2 years. 2 years. Because they have treatment, they have education, they have separation, and then you know what? They're taxpayers. It works. It does work. But we've got to draw the line in the sand for what we're willing to accept and tolerate. And as a juvenile judge, I am not willing to accept and tolerate going to another funeral for a child in my court. I'm not willing to accept it. I'm not willing to accept insurance telling me they are not going to pay for treatment for a child. So we've really got to draw the line in the sand. Treatment works. if you have the money and the places to treat and treat the problem. Treatment is not an incarceration at $50,000 and $100,000 a year, because they're getting out.
Thank you very much. And everyone, I see different disciplines of different fields. Like I see the Human Service District is here. As you hear the panelists speak and everybody really knows each other here, reach out to one another if those resources can be integrated, or if you've heard something that the light bulb goes off and you can work with Judge Edwards. Think it through, because that's another thing that we'll learn a lot today, but hopefully we can network a lot today. So thank you so much, and your words are so well said. Thank you. Okay, we're going to turn the page now, and we're going to go to the Attorney General's office, Mr. Randy Henagan. Talk a little bit to us about naloxone and the program that the Attorney General's office developed, because it's very quite unique, and I think it's probably one of a kind in the United States. Talk a little bit about that, and let's talk about maybe just from your perspective, from your vantage point, what's working, what's not working. And thank you for being here.
Thank you for inviting me. Naloxone, or Narcan as most people know it, is basically the antidote for an opioid overdose. It is a chemical that basically stops the receptors from the opioid addiction. Okay, it blocks the pain. The opioids block the pain, and Narcan does just the opposite. It breaks it loose. Okay. The Attorney General's office received a settlement from Pfizer several years ago, and part of this settlement was that Pfizer agreed to allow the Attorney General's office to provide Narcan to first responders. This program is done through our office, where a agency can contact them. They will receive a request document. They fill it out. If they fit the requirements, they will give them vouchers for 10 Narcan units. These units are free of charge. They will go to a pharmacy in their local area and receive the Narcan units. They mostly are used by fire department, EMS. We've had a couple of police agencies who have contacted us, but mainly it's been fire departments and EMS. It's been very successful. I believe we've done over 2,000 different units that we've given out. It is free of charge to the agencies. There is no cost to them at all. Narcan is becoming more and more available to the public. Now, most of the major chains will give it, they will sell it to a person without a prescription. Some of it is very expensive, some of it is cheaper, but there's drawbacks to that also. There's a lot of people believe that all you're doing is enabling people. It's giving the people the thought that I don't have to worry about overdosing. I've got this. Whenever we dealt with prescription drug abuse, they would call farming parties. People would come in, they'd have a big glass bowl, they just drop pills in it. You brought pills, you invited in, everybody just took pills. They are now starting Narcan parties. Everybody come in, as long as somebody's got Narcan, everybody parties.
Oh my goodness.
It is a horrible thing to think about, but it's there. This is an issue that law enforcement, EMS, fire department, and everybody has to deal with. Because you go to a party and there's people with 10 Narcans, and there's 100 people there. What you gonna do with the other 90? We will have to deal with them, all of us. Healthcare, law enforcement, everybody will. I think Narcan is a wonderful thing, but it's just like a lot of opioids. OxyContin was a wonderful drug for the people who needed it. Chronic, severe pain, it is a wonderful drug until it got abused and it opened the floodgates. People get addicted to prescription pain pills or anything else, and it progressively moves on. For law enforcement, it's actually moved on into the aspect of just like every other drug. It moves on into heroin. Heroin has gotten extremely potent, and it's gotten extremely cheap. Heroin used to be very expensive, and not everybody would use it. Number one, they had the stigma of the needles. Now nobody cares about needles anymore. For whatever reason, everybody don't care about them. They're using heroin. Heroin is getting laced with fentanyl. Fentanyl is a horrible thing when misused. Fentanyl is transdermal, and that becomes an issue for law enforcement and first responders again. It will affect you in a matter of seconds, and it does not take more than just a couple of grains of salt to kill you. Carfentanil is even worse. This is a problem that everybody has, not just law enforcement, not just first responders. Because if you work in a hospital and somebody is brought in and they have fentanyl on their body somewhere and you touch them, you just became contaminated with it. That means everybody in this room could be contaminated very easily. It is a horrible thing that people are making. They're making this in their homes just like they did meth. The biggest part of the opioid addiction has become when people get hurt. They can be in a car wreck, anything else. They go to a doctor. Doctor gives them medication. Like I said, the opioid blocks the pain. It does not solve it. A pill is not going to solve a problem. It's going to block it. They get addicted to it, and it progressively gets worse. I don't remember who said it, but one of them on the first panel, I think it was Dr. Gee, said, Jennifer said, people don't start out, they don't wake up that day saying, I want to be an addict. It becomes that way. Everybody has the possibility of becoming an addict. Some people are more likely to be it, but everybody has that possibility to anything. The opioid addiction has became such a huge thing. I was reading last night, Judge Edwards just said that the Americans have such a wide range of it compared to everywhere else in the world. I think I read last night, 80% of all opioid prescriptions are written in America. That means 80% in the world. There's another statistic that I had found a little while back. The Vietnam War was approximately 20 years. In the Vietnam War, there was 58,220 Americans killed. In 2016, there was over 62,000 Americans killed through opioids. In 1 year, we lost more Americans than we did in 20 years in a war. That's a horrible thing to think about, and it's just astounding to think about that. To me, the Narcan is working, but it has its drawbacks. It's just like everything else. I think the treatment centers are the best way we're going to get any help for the people addicted. It is something that no one thing is going to fix. It's going to take everybody working together to do it. It's not just the doctors that's going to cause the problem. It's not just the doctors that's going to solve it. It's a lot of people working together.
Thank you so much, and you've given us so much food for thought, and I think it makes it for the next segue. Mr. Jones, Mr. Lee Jones, could you, let's talk about a successful model, the mobile treatment clinics, and how we can all partner up. Tell us a little bit about that, please.
Thank you, Senator. Honored to be here today, and glad to be able to address you guys and talk a bit about rural development's role in this battle with this addiction. You know, our eyes have been open today about all the problems and how horrible it is. I hope to be able to equally open eyes in relation to the resources that are available. So some of I'll talk just quickly about the resources in terms of the programs that are being offered through rural development, and then segue a bit into some of the successful models that are taking place across the country. One of those things that we talk about is the distance learning and telemedicine grant that Betty Ann talked about a bit earlier, and it was designed with the notion that it was designed to provide access to education as well as healthcare in rural communities where it otherwise may not have been available. Now we have such a focus on opioid recovery and addiction that a lot of that money is being set aside now to address addiction and treatment. And as with any other grant that you apply for, of course, there are points that are awarded, and that's how it's determined how you know how successful you are in approaching that. There are points that are available for those that are addressing opioids. So we want to make sure that you're aware of that. But in addition to that, you know, the community facilities program offered through USDA Rural Development is readily available, and it's designed to do those innovative things such as rural treatment facilities, such as in Pennsylvania, where they are doing mobile treatment facilities using RVs or tractor trailers or things like that. And those are the innovative ideas that we are looking for and looking for opportunities to fund. As much as we like doing the police cars and the fire trucks in the rural communities, and those are necessary, don't get me wrong, we are looking for those innovative ideas and those opportunities to fund those kind of facilities. Those of you that are in and drive through rural communities, and even urban settings for that matter, but if you're driving through a rural community, you probably often see vacant facilities, vacant buildings that are there and available for use. And if you ask that mayor, they're going to say that needs to be used for the next manufacturing facility that's going to solve all their unemployment woes. But that's not, that's not always a reality in in these communities. But what might occur is, such as in North Carolina, where they used those vacant buildings to develop a family resource center, and that resource center was designed with the idea in mind that opioids that's a family addiction. Addictive disorders in general are family addiction, family disorders. So that treatment facility was set aside in order to address family resources, bringing in the entire family, mom, dad, brother, sister, aunt, uncle, and the like, to have an opportunity to talk about how we recover as a family, how we move forward, and rural development is there to be able to provide those resources. Thank you.
I guess one follow-up question, because there's so many of us here, that who do you find the best strategic partners in a community to partner up with? Is it the government sector? Is it the hospital? Or, where would you say would be the best strategic partners to join forces with the programs?
Well, I think we're all. I mean, everyone in this room is a valuable partner. So whether it's the hospitals, even the urban setting, the hospitals in urban settings. I think about what Lafayette General is doing in this area, where they are really reaching out into the rural areas and doing a great job of not only revitalizing some of these rural hospitals that tend to struggle from a resource perspective, and then you bring in your municipal officials, and it really takes, we used to have a saying in the community that it takes a village to raise a child. It really takes a village to address this issue as well. So I mean, all of us play a role, and so whether we're approaching it from the perspective of having the funding that people need to address this disorder, or looking at the folks that can help identify those that need the treatment. I think what Jennifer spoke of earlier was extremely powerful in terms of the people that are in long-term recovery, using their voices and speaking up as well. So I mean, rural development is there to provide the funding, but we need the people with the ideas and the innovative tactics to come to bear, and hopefully we'll have an opportunity to work with them.
Thank you,
provide
Mr.
some of those
Jones.
services.
Thank you so much. Jennifer, once again, your speech was inspiring, and now I guess we'd ask you, let's talk about access to treatment, distance, transportation. Just talk to us about all that and give us some insight from your vantage point.
Well, you took away the first thing I was going to say, because the question they were going to ask me was, what are the biggest hurdles preventing access to medication-assisted therapies? And I was going to do a gentle redirect pivot.
I missed the dress rehearsal.
He did it for me, that's the wrong question. The right question is, what are the biggest hurdles preventing access to the type of treatment that is going to work for the type of person who needs the help? Not one treatment is going to work for every single person. And it used to be the average person who actually got treatment would go into a treatment center, and then they would finish that program, and they would say, go to AA, thank you, goodbye. Now, I'm a fan of 12-step programs. I think they're wonderful, but not everyone likes them. They don't work for every single person. Why? I don't know. And now what I'm noticing is that there's a shift away from, look, go check into these 12-step programs that are available 24 hours a day and are free and all of that, over to, let's just get you into some medication-assisted treatment, medication-assisted therapies. You know what? Those are wonderful too. Thank God we have them. But that's not the only solution here. And the solution is going to be like what you talked about, which is it's a lot of different things, and it's people getting together and bringing their different areas of expertise and learning more about the disease of addiction. It's like breast cancer 20 years ago. Everyone got the same treatment, and a big group of people died. And now what we know is there's lots of different kinds. There's subgroups in there, and we can check for that, and we can tailor treatments, and survival rates have skyrocketed. And it's going to be the same thing with addiction, the more they study it and the more they know about it. But specifically, what are some of the biggest hurdles? I'll get into some of the real nitty-gritty ones, but the first one that I want to say that I think is huge is stigma. And we've got to change the way that we think about substance use disorders. And there's a word that just makes my skin crawl, and everyone here is here for the right reason, so I hope it doesn't seem like I'm chastising anyone. There's two terms, and one of them is addict. When you hear the word addict, does anyone in here think of someone that looks like me? Or do you think about someone who's living under a bridge? Or someone who's stealing stuff? Or someone who's hurting people? I don't ever want to hear that word again. You know what we used to call people with developmental delays and people with special needs? We called them morons. That was a technical term. Feeble-minded. Okay, so that word's got to go. And I mean, I wish Senator Cassidy was still here because he'd be like, oh God, there's that Jennifer Holmes again. I can't tell you how many times I have sent letters. The New York Times is so sick of me. The Washington Post, it's ridiculous. There is a Surgeon General report that was released a couple years ago, and he did a follow-up letter, and I think you can find it if you go to Surgeon General, the language we use when addressing addiction. And he talks about, instead of saying addict, say a person with a substance use disorder. Yes. Huge difference. The other term that kills me is substance abuse, drug abuse, alcohol abuse, because guess what else gets triggered in our brains when we hear that word? Sexual abuse, physical abuse. You know, I wasn't abusing alcohol. Alcohol was abusing me. So I don't ever want to hear that term again, either one. You want to take one thing away from today? Don't use either one of those words. It's substance use disorder or a person with a substance use disorder. There are, yes, lots of real specific hurdles as well, like finding providers. Medicaid, actually you get better coverage with Medicaid than you do with other insurance companies. But in order to find a provider, right now, if you want to get into the Medicaid covered program in Orleans Parish, there is a 6-week wait for an appointment. If you want to be a walk-in patient, there is a counselor that's available on Tuesdays from 3 p.m. to 4 p.m. That's it. And those are the lucky people that get that. And then let's say they get that appointment, it's another month to 2 months before they can get in and see a doctor. Minuscule the amount of people that actually get coverage. So I'll stop there. I could go on and on, obviously.
No, this was perfect. And we learned a lot from you today, Jennifer. Not just one or two things. We've learned a lot from you. You know, we do have some time, and I think Senator Cassidy and the Secretary did have to leave. Because if anybody's heading to Baton Rouge right now, the line goes all the way to Maringouin. So while we do this, why don't we open it up if you could? Let's with the four panelists.
Go ahead and open it up. Randy and I are sitting here on the panel, and we have to go to Baton Rouge, so we'll be here a while.
You will. You might as well stay and have supper. Exactly, because I make the drive, and when I'm coming back from the Capitol, it's lined up for about 20 miles. I'd like to meet the engineer that designed I-10 to turn into one lane, wouldn't y'all? Yo, why don't we, with the panelists, would y'all be okay to take a few questions from the audience?
Sure, we don't have anything else to do but sit in traffic.
Exactly, Judge. Let's open it up. Does anybody, we have a wide variety of expertise on the panel sitting here. Does anybody have any questions or any thoughts that you have that you could maybe also integrate with your thoughts? I see we have the Acadiana Human Service District here. I see we have different types of medical providers, rural health clinics. Anybody would like to bring something up that can either add information or challenge our...
Senator, can I just say one thing?
Oh, please.
Jennifer just said something that I think is just unreal. You heard how hard it is for someone to get into those doctor's offices. And the one thing that is not hard, I can tell you with, I hear this all the time. I was not a personal injury attorney, but let me tell you, they have personal injuries clients. They go into doctors, they are like clockwork. They go to chiropractors, doctors show up, and they write prescriptions like this. It's amazing to me that it's easier to get a prescription for an opioid than it is to get into a doctor to see someone to help you prevent from being a substance, to having a substance use disorder because because you have access. So I say restrict the access. Because what they say in Japan is you don't have to have an opioid to treat your toothache. You don't have an opioid to treat your ankle sprain. And I can say that when my son was 15, he went to the emergency room for a concussion in a football game. And as I sit there, we're getting ready to leave, and I think that's it. Until the nurse walks in the emergency room and says, here is a prescription. And granted, the doctor did not do anything wrong. Not anything wrong. But he did. He wrote a prescription for hydrocodone and muscle relaxers to my 15-year-old son. And I was astounded. And I tore it up right there and I said, is this going to fix the concussion? No, it's going to block the pain. So I'll give him Motrin when we get home. So I say that we can't get in to see the people to fix it or help us fix it. So why have the access to it? There's nothing wrong with pain.
Thank you. Anybody wants to? Yes, sir.
Don't worry about it. I'm loud. Don't carry. And Fred, you know that.
Exactly.
Cian Robinson, Executive Director, Lafayette General Foundation. Question for the panel. We are doing quite a bit, given the rurality of our footprint, we're doing quite a bit with telemedicine. Okay? And thank you to the USDA Rural Development Authority for helping us fund some of that with the schools. My question to you is, have you seen an effective solution that can be telemedically delivered, given that access seems to be such a challenge?
Yes, ma'am.
Well, I don't know that there's any one solution that would be a catch-all, obviously, but just in terms of the examples, especially with LGMC participating in the distance learning and telemedicine grant, some of the opportunities that we've seen out there using that program. There's opportunities in other states where there's limited access to mental health services and the like. Inadequate insurance coverages, and they were using this telemedicine program to create a rural network that covered almost a third of the particular state that I'm referring to. And I mean, they've been a frequent recipient of this distance learning and telemedicine program, and they're able to provide comprehensive care in those high need communities. I'd be remiss if I didn't say that despite the fact that we're called rural development, it does not mean that we don't reach into urban communities. In such cases, the distance learning and telemedicine, usually the anchor of that grant is in an urban setting, because obviously the services are not necessarily readily available in that rural community. So the anchor is normally in an urban setting where they can reach out into the rural communities. And I mean, we've seen some really life-changing, life-saving things that have happened across the country using this distance learning and telemedicine grant. And that that's an opportunity that's only open for a particular period in the year, but we do have other programs that are open all the time, such as that community facilities program that I talked about earlier, that could help address some of those opportunities as well, that likewise could be used with an urban setting as an anchor. So again, while I don't know that there's any one solution, there are multiple examples across the country where there have been successes, and we're hoping to have some of those opportunities here in Louisiana to address it as well.
See, and so I also might mention our USDA opioid website has a list of best practices. If you scroll down towards the bottom, there's a number of different opportunities for you to view and see what other states are doing. Mobile clinics is one of them that I think is just absolutely phenomenal. You talk about access, transportation needs. There are things that we can do to be able to help provide those services as well. So go on there. The other thing is that webinar. So I'm on the USDA opioid task force, and we're about identifying what these options are and being able to communicate that to everybody, because what might work in North Carolina might also work in Louisiana. What might not work in Nebraska might not work here in Louisiana. So we're about identifying what the options are, making sure that we're addressing some of the cultural issues that we have that are unique to Louisiana. But go on that website, and what I would hope that we would do is if anybody knows of any potential opportunities or any ideas that we need to look at and explore, let us know. We'll go ahead and take that all the way to Congress, to DC, whoever needs to know.
And Carrie, what we're looking at is, I think we're gonna try to get away from not wholly sort of distributed network that we're talking about that you all funded, but we're looking more at these things, right? And specifically for what you all are talking about for the particular counseling that is the ongoing counseling that's required.
So I sure hope that our hackers that are working 24 hours are going to be coming up with solutions for these types of devices. It's interesting that USGS has an app, especially after earthquakes, and it asks you a question. How did it feel? So in other words, how did you feel? What happened? And I'm thinking, why can't we use that for health? Where you can have almost instantaneous data for those that need to provide information to those who can use it. We talked about data. How do you feel? How do you feel today? How did you feel yesterday? How do you feel this afternoon? How do you feel after this event? So there's really unlimited possibilities. We just need to put our thinking caps on and make sure that we have the right people in the room. To your point about making sure that we have the recovery community involved, that's the first time that I've heard that. It's not going to be the last time that we hear it either. So thank you.
I wanted to say that there's sort of just what she said. There's a huge untapped resource in the rural communities, which is the recovery community. And there is a program that is somewhat funded called peer support specialists. And these are paid positions. They're not paid well. They should be paid a lot more. But it's people who are in recovery who help assist other people in recovery, both getting into treatment and that process of leaving treatment and re-entering the community that is really hard. So underused, so inexpensive. There's a great story that I think can apply to recovery, which is if you look at a sick tree. You ever seen a sick tree, a sick and dying tree? And it's in sick and dying soil. And someone takes that tree and they dig it up and they bring it into the sunshine and this beautiful soil, and the tree gets beautiful and healthy. And then what we do when we say, okay, it's time to go, is we take that tree and we throw it back into that old soil, and we wonder why the tree gets sick again. So the peer support specialists can be that segue back into the recovery community where people can get well and stay well with the sustained treatment that they need. Thanks.
Thank you very much. We almost complete with the program, but Secretary Gee is still here, and I'd like her just to address you before she heads off to Baton Rouge. And oh, I'm so sorry. Yes, ma'am.
About the three of us teach nursing at UL. That is a piece of psychiatric nurses or people that work with patients. A lot of times are not at these panels, but sometimes after they have an intake assessment, we might be the second person who does an assessment on somebody coming in for treatment. But I just have a quick question about the responsibility of the person himself or herself to do what they're being asked to do in recovery. Because sometimes it's hard to even get them out of bed to go to group. And we cannot, we're told, well, you can't make them. So somewhere in the discussion, even the doctors writing prescriptions, they're not forcing people to swallow the excess pills. At some point, do they have a responsibility and some accountability?
So from your vantage point as a practitioner, you pretty much take it to where it needs to be, and where is the responsibility on the patient side? Sure.
We can all run around and try to do this and try to do that, but if they won't listen, they won't do what they need to do,
Yes.
Let's keep in mind again that we're talking about someone with a disease and someone who's in active addiction. It's not really a choice, So this person doesn't get it. Their brain's not working. And we have to think about how do we get that person out of the active addiction to be well enough to listen to the important things that you're trying to tell them. And in order to do that, we need to raise their dopamine level. And there's lots of things that do that. I think Dr. Gee grew up in a community. And being in a community raises dopamine. Feeling connected to other people raises dopamine. Spirituality raises dopamine. So having someone like a peer support specialist who understands that, who can be there when that person's about to leave treatment and have a 5-10 minute talk with them, you're going to increase the odds that person stays and listens to exactly what you, as the professional, is telling them that actually works and helps.
And so sometimes we get to the point where the people are having severe consequences for the actions, and unfortunately it's because of a disease in many cases. And so I hear what you're saying, because I have these juveniles in my drug court, and it takes a while before they're ready to participate and be active in their recovery, if at all. What I do see is exactly what Jennifer's saying. Their recovery is based on the support that they have. And oftentimes, we don't even start out talking about the disease or the drug that they're taking. We start talking about what's underlying, whatever started this. And, if you start off with, well, I had a back surgery and I got prescriptions, that's a whole different kind of treatment than it is, well, when I was a child or when I was younger, I was abused and I have, PTSD from what's going on. So you first have to find out where does the substance use disorder originate? Does it originate through from the actual taking of the drug because of some medical situation, or does it start from, and I'll just say, self-medicating because of some pain you feel within? And then you have to, the support is key. Support, whether you're the medical support, whether you, and I think that's where education on the ACEs come in. If any of you have heard of ACEs, has anybody heard of ACEs? The Adverse Childhood Experiences, which is one of the #1 public health concerns in the nation, which goes to all of this, and also to being trauma informed. That's where you can be of great support as a medical professional, is to be informed about that, also with how you begin the treatment.
Great. Well, our time is up, and I wanted to thank the panelists and thank our prior speakers. Dr. Gershanik's data was fantastic. It was wonderful to bring Bruce back home. Senator Cassidy had very insightful remarks. Jennifer, you moved me to tears but taught me some new lessons. So thank you, everyone, for coming. It's wonderful to be in a state that has so much going on. We are, despite the fact that we have challenges, so coordinated, and all of us are activated, understanding this is a problem. And let's leave today with a commitment to do what we can to fix it, to help those in recovery, to reduce stigma, and to do all we can to make sure no one dies. Remember, naloxone is available at any pharmacy in the state, and if you know someone who may be at risk, keep it stocked, educate, and make sure as we fight this problem, let's make sure that people don't die while they're getting on the path to recovery. So this has been a phenomenal day. I really thank UL and Ramesh and Henry and all of the folks here, are wonderful young people who are going to fix this problem for the future and innovate. Thank you so much, and I will